Hi, everybody. This is Rajem Roos, the founder and CEO of the San Diego Pain Summit, and I'm here with Dr. Catherine Siengsukon. And I guess if you don't mind I think you're muted. Oh, maybe I muted. There we go. There, I like that look better.
Not so close up.
Yeah, I know, the big head and the thing is. And so just to remind everybody who's watching, there is about literally a 2-minute lag between the videos. So we're going to make sure and take that into account when we do Q&A, when we pull questions in. So I'd like to introduce Catherine Siengsukon. She provides instruction in neuroscience, neurorehabilitation, and sleep health promotion in the physical therapy and rehabilitation science doctoral degree programs. As director of the Sleep Health and Wellness Laboratory, Siengsukon's line of research seeks to understand how sleep impacts function, learning, and overall health, particularly with aging and in those with neurological conditions. She possesses a clinical background in outpatient physical therapy, treating individuals with musculoskeletal and neurological injury. Siengsukon is an active member of the American Physical Therapy Association, and she has served on the research committee for the association's neurology section, and she is past chair of the research committee for the Kansas Physical Therapy Association. Siengsukon received the 2014 Rising Star Award in Health Professions from the Women in Medicine and Science at KU Medical Center. And so before we show your talk, is there anything that you would like to show us?
So I thought long and hard about what I wanted to share. So it's not sleep related and it's not pain related. So a little bit about myself. I'm sharing a book that I'm using to plan an upcoming trip. I love to travel. I have 4 kiddos and I love to have them experience national parks. So we were just out in Estes a few weeks ago, actually, and so my prayers for people who are being affected by the wildfires now. But we're planning a trip out to Utah, hopefully in the spring. So just a little glimpse into my life other than my research and my teaching.
Cool. Thank you so much for sharing that. And I hope that your trip goes really well. That's really neat. That's just a beautiful country. And I was recently in Estes Park too last year. So yeah, our thoughts are with the people of Colorado right now. So what I'm going to do is I'm going to go ahead and start the presentation just to remind everybody the presentation is pre-recorded, but we are live in the introduction and the Q&A is going to be live as well.
Hi, I'm Katie Siengsukon, and I am very excited to be a part of this conference and to talk to you today about the relationship between sleep and pain and what can we as physical therapists and PTAs help our clients sleep better. Here is my disclosure, and here are the learning objectives for this content. We'll first talk about the relationship between sleep disturbances and pain. We'll then go over how to select and implement appropriate screening tools for the most common sleep disorders in adult, and specifically for adults with persistent pain, and then also to incorporate strategies into practice to help promote client sleep health and tailoring that to individuals with pain. So we know that between 50 and 88% of individuals with chronic pain experience sleep disturbances, and that sleep insufficiency is associated with increased frequency and intensity of spontaneous pain, lower pain thresholds, and increased pain sensitivity. And this has been shown to be true both in experimentally induced sleep insufficiency, so individuals who are otherwise healthy and underwent experimental reduction in their sleep, either duration or quality, as well as in individuals with insomnia. And there's not a lot of studies that have looked at the prevalence of sleep disturbances in clients seeking PT services, but there have been a couple studies that showed that between 92 and 93% of patients with low back pain who are receiving PT services report poor sleep quality. So for the physical therapists and PTAs that are participating in this conference, you probably are already well aware that a lot of your patients who have pain are reporting sleep issues, but it does appear that there's a fairly high prevalence of poor sleep quality in people seeking PT services, at least those with low back pain. So I do want to kind of set the stage for knowing that sleep is important for many different systems within the body. Obviously, we're focusing on sleep and pain today, but I do want to point out that sleep is important for pretty much every system of the body, from our immune function to tissue healing, cardiovascular health, cognitive function, learning and memory through neuroplasticity, neuroprotection, and as well as metabolic and endocrine function. And we, of course, are focusing on how sleep can modulate or lose the ability to modulate pain. And people who experience chronic sleep loss, they are at an increased risk of developing various chronic conditions, one being depression, anxiety, diabetes, obesity, cardiovascular disease, Alzheimer's disease, and then persistent pain. So again, even though the focus of this lecture is on sleep and pain, I do want to point out that people who have chronic sleep loss are at an increased risk of developing several different chronic conditions. And if that's not enough to convince you that sleep's important for our health and wellness, chronic sleep loss is also associated with an increased risk of mortality. So there's likely many mechanisms as far as how sleep does contribute to disrupted pain modulation. And so there's a lot of different studies, and the summary and what appears to be the case is that chronic sleep deprivation appears to result in disrupted ability of those central pain modulatory systems within the brain to modulate pain. And so there was this great review by Fenton and colleagues back in 2013. I would highly encourage you to read that. But they found in review of many different studies that it appears that chronic sleep deprivation results in the disruption of those descending pain pathways as opposed to an amplification of the ascending sensory pathway. So it does appear that chronic sleep deprivation impacts the ability of the brain to modulate pain using those descending pain modulatory systems. And there was this great review that was just published this year by Hack et al. That looked at the various mechanisms that also are likely contributing to the disruption in pain modulation in people who do have persistent sleep issues. It also appears that reduced sleep quality interferes with the normal regulation of immune processes. That also leads to an increased neuronal sensitivity and pain perception. And there's been some interesting evidence looking at the role of glial cells, and that sleep disturbances can lead to glial cell overactivation, which then can also lead to a neuroinflammatory state and thus increase the excitability of the central nervous system and thus contributing to disrupted pain modulation. So we know that sleep and pain are bidirectional. I mean, that probably makes intuitive sense. For those of you who are clinicians, you've probably experienced your clients who you're treating for various conditions who have pain. They're likely reporting disrupted sleep, and that probably makes a lot of sense. But there's been a whole lot of research and interest in understanding how exactly is sleep disrupting pain. And this was the Fenton review that I had mentioned prior that I would encourage you to read, where they did a review of the longitudinal prospective studies as well as the experimental studies. And their summary, as far as looking at that direction of is pain contributing to sleep issues or sleep contributing to pain issues and how, they actually found that sleep disturbances are a stronger predictor of future pain than pain is of sleep disturbances. So if you have disrupted sleep, you're at a higher risk of developing a persistent pain condition 5 years, 10 years, 15 years down the road. And they also point out that efforts to prevent and treat chronic pain may well be served to target sleep disturbances as a point of primary prevention as well as intervention. And so I think that's where our role as PTs and PTAs can certainly come into and helping to promote optimal sleep health in our clients. So cognitive behavioral therapy is a treatment that addresses both the behaviors and the negative thoughts associated with the maintenance of insomnia. So CBTI is a technique that I've been trained in, and we actually are doing several different studies within my lab on looking at the impact of CBTI in various patient populations. So we're looking at older adults and how does it impact cognitive function, and reduce a rate of beta amyloid accumulation. We're also doing a Cvti study in people with multiple sclerosis and how does it impact their sleep, their fatigue, their depression, their anxiety. I have a PhD student who's just about ready to start her dissertation project on the use of Cvti in people with concussion and how does that impact their sleep as well as their concussion symptoms. And I'm not suggesting that everybody go out and get trained to do Cvti, but I certainly think we can glean the main tenets of Cvti and incorporate that into our physical therapy practice. So the main components of Cvti, one is sleep restriction, and I prefer to use the term time in bed restriction because we're not actually restricting sleep, we're actually reducing the amount of time that they're spending in bed. We also use stimulus control, and so that's a technique to help the brain pair the bed with sleeping as opposed to associating the bed with worry, anxiety, pain. Also focusing on sleep hygiene, relaxation techniques is a big component, and then also cognitive therapy, so we can address those negative thoughts surrounding their insomnia. And Cvti has actually been shown to be more effective long-term compared to pharmacological interventions for insomnia, and the effects for Cvti has been shown to be maintained for at least 10 years, which is pretty incredible. And so I know this is a busy slide, but these are a few of the studies that have shown that Cvti is in fact effective in people with chronic pain. There's been several studies that have done Cvti alone as an intervention in people with chronic pain and have shown that it does in fact improve their sleep and that there has been a moderate to large effect on their pain severity. There's more recently been studies that have looked at Cvti, so cognitive behavioral therapy for insomnia, and then CBT specific pain, where they've done a hybrid or use those techniques together. And my main take-home message for you is that these studies suggest that Cvti, either standalone or in combination with treatment for pain, can improve insomnia symptoms as well as have some reduction in pain as well. And so it suggests that addressing both sleep and pain in people with chronic pain who have insomnia may produce superior outcomes than just addressing sleep alone or pain alone. And so I think that adds the impetus for why PTs, PTAs should be incorporating some of these techniques into our clinical practice. So what should we do? I propose that there's 3 different steps. The first step is to screen all of your patients. And we'll talk about how to go about doing that. We developed a decision tree to help guide clinicians on how to screen patients for sleep issues. And then we'll talk about how to tailor your sleep health promotion techniques for your particular client that you're working with. And it really is very important to tailor these recommendations. So just like you wouldn't take, a handout about exercise and hand that to your patient and say, okay, we'll go exercise. Same thing is true with these sleep health promotion techniques. You wouldn't just take a handout and hand that to them and say, okay, go sleep better. So you really do want to make sure you're tailoring it to the individual and then referring as needed. In the decision tree, I'll talk about the different cut points on knowing when to refer for further assessment for a sleep issue. And so you may need to refer to a physician for further assessment of their sleep disturbance. And ideally, that would be a referral to a physician who's board certified in sleep medicine. And I'll talk about how to locate one of those physicians. And then also, too, having a network of referrals that you can send individuals to if needed, psychologists, social work, because I will say, as you start to talk to clients about their sleep, sleep is a very personal behavior and activity. They're inviting you into their bedroom, they're inviting you into their home, into their personal relationships. I will also say that sometimes traumas can also be discussed. It can come about that there was a trauma that had happened or some other significant life event that had happened that is contributing to their sleep disturbance. So absolutely knowing when to refer those individuals and how to refer those individuals. And then connecting people to local community resources. Unfortunately, I don't have enough time to talk about screening for social determinants of health, but I have a resource at the end that I'll share with you, and then knowing how to refer people to various community resources if they have a food insecurity or home insecurity, things like that, because it's very difficult to empower your clients to sleep better if they don't have adequate access to good food or to a safe sleeping environment. So here is the sleep decision tree. So I actually developed this in collaboration with Ken Miller and the home health section. And so this is available if you are a home health section APTA member. We also have completed a study to see if physical therapists can apply this decision tree to hypothetical patient cases, and we're getting ready to submit that publication or the manuscript for publication. So this will be available. I'm also happy to share it with you if you would like. But so you start up on this left-hand side, and you first ask 3 questions. You ask about how many hours of sleep do you typically get. So we're starting to look at sleep duration. And I think people oftentimes think, well, gosh, if I ask about the number of hours of sleep, then my job on asking about sleep is done. And that's not true, because you can get 8, 9, 10 hours of sleep and have really poor sleep quality. So you need to ask about sleep duration and then also asking about sleep quality. And so we start to get at sleep quality by asking question number 2, do you feel well rested when you wake up? And then question number 3, how would you rate your overall sleep quality? I tend to leave that as an open-ended question because I think it's actually oftentimes telling to hear the words that the clients use to describe their sleep. But if you would like, you could also then follow up that question with, would you say your overall sleep quality is very good, fairly bad, or very bad? And then based on how your client answers those questions, you then have 3 different decisions to make. This top decision, these are your good sleepers. These are the people that are getting at least 7 hours of sleep each night. They're feeling well rested when they wake up, and they're rating their sleep as fairly good or very good. So they are at a low risk of a sleep disorder, but you absolutely want to encourage the positive sleep behaviors that they're exhibiting. So certainly reinforce those positive behaviors. And then this next decision, these are the people that genetically have a short sleep need. And I'm going to be honest, I actually considered leaving this decision off because there's such a small percentage of the population that truly genetically have a short sleep need. But so if the individual says that they're getting 6 to 7 hours of sleep, if they're waking up feeling well rested, and if they rate their sleep as fairly good or very good, it's possible that they genetically have a short sleep need. What I find when people generally say like, oh yeah, I get 6 hours of sleep, maybe 5 hours of sleep, and yeah, but it doesn't bother me at all. I function just fine. I usually follow up with, okay, so how many hours of sleep do you get on the weekends? And then they'll say, oh, well, I usually sleep in on the weekends. And so then I gently, hopefully kindly say, well, if you really only genetically needed 5 hours or 6 hours of sleep, then that would be true even on the weekends. So do just be cautious because you probably will come across people that report that they only need 6 hours of sleep, but truly they don't. They need more. Most of us need at least 7 or more hours. But a lot of our clients are going to fall into this decision where you go down. So you then would consider their condition for why they've come to see you in physical therapy. Is there acute condition or their condition that they're seeing you for? Is that impacting their sleep? If so, and how is it doing so? Because it probably makes a lot of sense that somebody who has an acute injury, so now they have an acute bout of pain, or maybe they have a flare of their pain condition. It is apparent that their condition is contributing to the exacerbation of their sleep difficulty. So then you would go to the left to this yellow box, and then you would do your fantastic PT intervention, treat their condition, and monitor their sleep. Because then if their sleep resolves with the resolution of their acute condition, then absolutely encourage those positive sleep behaviors. They likely don't have a sleep disorder. But if your fantastic intervention does not improve their sleep, or if it's apparent that they've had sleep issues prior to that acute condition, or it doesn't seem like their condition is contributing to their sleep issue, then you go down to answer or to ask questions 5 through 8. So now we're starting to look at risk of insomnia, sleep apnea, and restless leg syndrome. And I fully can appreciate that we are not board certified physicians in sleep medicine. There's over 100 sleep disorders, but I do think it's perfectly reasonable for physical therapists to be able to screen for the 3 most common sleep disorders in adults, and these are also the 3 most common sleep disorders in adults with pain conditions. So you ask these 5 through 8 questions, and then based on their response, you may then decide to do a questionnaire to assess for their risk of insomnia or their risk for obstructive sleep apnea more in depth. So then you would administer the Insomnia Severity Index, and then based on how they score, you may then refer them to a physician, or you may not. And then same thing with the Stop Bang, depending on how they score, you may refer them because they're at elevated risk for sleep apnea, or they may not be. And this is your decision point for restless leg syndrome. And then this decision here in that yellow box, down straight below from questions 5 through 8, that is to capture the other 97 plus sleep disorders that we are not screening for. So hopefully this gives a little bit of framework to help guide you in screening your patients for common sleep disorders. And I just for sake of time, I did not include the various sleep disorders in this lecture, but I have included the links so that you can access these questionnaires. And I did just check the links to make sure that they actually work, so they should be working for you. I will say, so here's the Insomnia Severity Index to look at insomnia. Stop Bang is to assess for risk of obstructive sleep apnea. The Pittsburgh Sleep Quality Index is the gold standard to assess for sleep quality, and it's very well used in clinical practice as well as in research. You are supposed to ask for permission to use it, and I've provided that link. My issue with the PSQI is that in its original format, it's kind of clunky to use. So I've also included a link to an easier scoring format. And then the Epworth Sleepiness Scale is a great tool to assess for daytime sleepiness. And I've provided the link to access that questionnaire as well. And so I would suggest and I would recommend using the PSQI and the Epworth at your initial visit with your client to screen to look at sleep quality and daytime sleepiness, and then re-administer them at the end of your episode of care. So that way you can see if their sleep quality and their daytime sleepiness has in fact gotten better. Another potential assessment tool you could use is a sleep log. This is actually the sleep log that we use in our research studies. This may be more in depth than what you need for your patients. So if you Google sleep log, there's lots of different types that come up. We ask about their naps. If they napped, how long was it for? What time did they get into bed? What time did they get into bed with the intention to sleep? About how long did it take them to fall asleep? What time did they wake up? What time did they get out of bed in the morning? How much time did they spend lying in bed awake? How much time were they out of bed awake? And then if they have any other comments. And so we do use this in our CVTI studies because it helps us to tailor the intervention to the individual, and it also helps us to gauge if the individual is following the recommendations. It also, and why I would recommend that you might consider using it, is that it also is very insightful for a lot of our clients to help give them kind of an objective way to look at their sleep over a week. Because I've had lots of clients say like, gosh, I didn't realize that I was napping so often or for so long, or I didn't realize that my bedtime and my wake up time were so variable. So some ways it is very insightful for patients to see what their sleep looks like. My one note of caution is that for some people, keeping a sleep log can actually make their sleep worse because it makes them really attend to their sleep. And I also tell people not to watch a clock to fill this out. This is meant to be an estimate. So in some people who can't not watch the clock, or this actually interrupts their sleep even more, then I don't recommend using a sleep log for those individuals. Another technique that to look at sleep is wearables. And you've probably had patients come into your clinic and ask you about the data that they're getting from their wearable. I hear it quite a bit. I think my biggest take-home message for commercially available wearables is that the majority of them have not undergone testing to see if they're valid and reliable measures of sleep. And that's a big deal because the accuracy of these devices are really kind of up in the air and really are not known. The studies that have undergone testing compared to polysomnography have generally shown that they either underestimate or overestimate sleep duration and quality. So they're not terribly accurate, which makes a lot of sense because these are basically accelerometers, right, that you wear on your wrist, and it's telling you if you're moving or not. So it's an indirect assessment of sleep. So there's algorithms that say, well, if you're not moving for a period of time, then you must be asleep. So I think that's the biggest thing to think about, is that these may not be terribly accurate. And so in that sense, I guess the other caution then is if it's not very accurate, it may prevent people from seeking out medical treatment if they truly do have a sleep issue, but their wearables suggesting that they don't. And again, I've had a handful of people that wearing a wearable actually disrupts their sleep even more because they know that their sleep's being monitored by this device. But I don't think they're all bad. I mean, I think there are some positive benefits of wearables. Probably the biggest one is just the increase in awareness of the public that wearables have brought to sleep and sleep health. So I think that is fantastic. People are just more aware of their sleep and they want to talk about it. So anything that I think enhances the start of a conversation with a healthcare provider, between a healthcare provider and a patient, I think is fantastic. So certainly I use these for opening up those conversations. And then Actigraphy. So this is a research grade wearable. I don't think these are very well used or very much used in PT practice yet, although I do oftentimes hear from clinicians that they consider using it. I think the biggest limitation is the cost, and then also the time that it can take to analyze the data. We do use Actigraphy for our research studies, and so it also monitors or detects movement, but they have undergone validity and reliability studies to show that they are accurate measures of sleep compared to polysomnography. Not perfect, there is still some error with Actigraphy, but they are valid and reliable measures. So this is actually a snapshot of data that we've gotten from Actigraphy, and so we can look at both activity levels and then also sleep duration. And then the next level of assessment would then be, of course, an overnight sleep study. So depending on how the client and how you progress through that decision tree, you may then need to refer for further assessment, which may include an overnight sleep study. But how do you find a board certified physician? Probably the easiest thing to do is to use this website, and you can search by zip code to look for an accredited sleep laboratory. And to be accredited, they have to have a board certified sleep physician associated with that laboratory. So that's probably the easiest way to go about doing it. You also can search by sleep medicine subspecialty. So for example, this is a snapshot of the website of the board for psychiatry and neurology. And so you can see where you can search for sleep medicine, and then you can search by state. So you can actually search by various subspecialties as well. That just is a little clunkier to do, but certainly you can. So now you've gone through the assessment of sleep issues. Obviously you're doing your other assessments that you would normally do for an individual with pain. I'd also encourage you to consider depression assessments as well, because that can oftentimes be an issue in people with persistent pain, and that can also contribute to sleep issues. So I didn't necessarily include depression assessment, but that may be something that you would consider. So now you've assessed the individual, and now you're going to discuss with them sleep promotion techniques. And again, I discuss sleep promotion techniques with everyone. If they have great sleep and their sleep's not disrupted, then absolutely reinforce the positive behaviors that they're already doing, and then absolutely tailor it to the individual. So I do want to talk about the physiological drivers of our sleep, because I think that helps set the context for why you're going to tell your clients to do some of these things. So we have two main physiological drivers of our sleep. One is our circadian rhythm, and that's this process C. And our circadian rhythm for humans is on a 24-hour schedule, and it is largely driven by the suprachiasmatic nucleus in our brainstem. And in particular for sleep, the suprachiasmatic nucleus tells the pineal gland to secrete melatonin, and melatonin is a very powerful hormone that tells our brain it's time to switch from being awake to being asleep. And then the other process is process S, and that's our sleep drive. So as we're awake during the day, adenosine builds up in our brain, and it makes our brain super tired. So then when we get into bed around 11 o'clock in this picture, our sleep drive is super high, melatonin's been secreted, so we get into bed, we fall asleep quickly and easily. Well, what happens if you don't sleep a night? What if you stay up all night working, or having a test, or maybe you're having a really bad flare of pain? If that happens one night, that's not going to really be sufficient to disrupt your circadian rhythm. Now, if that happens multiple nights, or maybe you're just getting really disrupted sleep, that can in fact either shift your circadian rhythm or can dampen the amplitude of your circadian rhythm. And so part of what we do in CBTI, and part of the techniques I'll recommend you to use with your clients, is to help strengthen that circadian rhythm as best you can. So then what happens with this individual is then they've stayed awake, so their sleep drive builds up super high. But then when they get into bed at 11 o'clock the next night, they fall asleep really quickly, really easily. They spend more time asleep, so that's an increase in total sleep time. They also spend more time in slow wave activity or slow wave sleep, and that's that deep restorative stage of sleep. So what we want to do is to help increase sleep drive and strengthen the circadian rhythm. And there's techniques that we can use to do that. The other thing I want to talk about is this model of insomnia, because insomnia is probably going to be it is the most prevalent sleep disorder in people with persistent pain. And so I want to make sure I talk about this in it, because it also helps to set the context, again, for why you're going to tell your patients to do the things you're going to tell them to do. So on this vertical axis, this is your likelihood of a sleep disturbance. And then the threshold here, this is this black bar, and that's the insomnia threshold. So if you're above that threshold, then you have insomnia. If you're below the threshold, then you don't. So if we look over here on the left in this kind of reddish color, these are called what's called your predisposing factors. So this is your genetic need for sleep, or your genetic susceptibility to various conditions. Or maybe you have a more hyperexcitable nervous system. Maybe you're a more anxious person. But those in of themselves are not sufficient to get you above that insomnia threshold. But then something happens. There's some sort of a precipitating event. Maybe you get injured and now you have an acute bout of pain. Or maybe you have a flare in your chronic pain condition. Maybe you get diagnosed with a condition. Maybe you lose your job. Maybe you have a fight with a loved one. Or maybe there's a buildup of several of these different precipitating factors. But those buildup or those things happen, and now you're above that insomnia threshold, and you have an acute bout of insomnia. So then what happens over time is people develop these perpetuating behaviors and thoughts. And so those are things like you spend more time in bed in the hopes that you get more sleep. Or maybe you start napping in the hopes that you get more sleep, or you start to get really worried that you're not getting sufficient sleep. So then as time goes on, that precipitating event either goes away or it gets diminished. But what's keeping you above that insomnia threshold are those perpetuating factors, are those behaviors and those negative thoughts surrounding sleep. So what we focus on with CBTI, and what I will encourage you to glean from CBTI to incorporate into your clinical practice, are these strategies to reduce these perpetuating factors. So we can certainly help people who have chronic insomnia improve their sleep, but I would also suggest and hypothesize that physical therapists are at a prime position to help people who are in this acute bout of insomnia, to help prevent it from becoming chronic insomnia, and potentially help those who are in acute pain condition to prevent that disruption in sleep, which then can contribute to an increased likelihood of that acute pain progressing to persistent pain. So why do I say that? So if we are working with people who are having an acute onset of a condition and they're in pain, or they're having disrupted sleep, what if we could help normalize that sleep disruptions are going to happen, and that's common, unfortunately, but they should be short term, and help guide them in ways to optimize their sleep right away, initially, right? And help prevent those perpetuating factors from developing. I would propose that we could potentially help prevent those acute bouts of insomnia that we see in physical therapy practice. We could help prevent those from becoming chronic insomnia, and also hopefully reduce the likelihood of developing chronic pain. That's what I propose. So what do we do? And if I had to pick one slide for you to become familiar with, this would be it. This is a great summary of what sleep promotion techniques you should be talking with your clients about. So the two biggies, and we'll go into more detail for each of those over the next several minutes that we have, but the two biggies to help strengthen circadian rhythm is to have a really regular sleep schedule. And the biggest part of the sleep schedule is a regular wake-up time. And then what naturally happens is when someone has a really regular wake-up time, their bedtime becomes much more regular. So I don't necessarily always, really, when I'm working with clients, we negotiate on what that regular wake-up time is going to be. And then to begin with, I usually give them kind of a window of when their bedtime is going to be, about an hour. Because I don't want them going to bed if they're not adequately tired. And that we'll get to this point of stimulus control. But what happens is, again, when they're really regular, their wake-up time, their bedtime becomes much more regular. And the other thing to think about is exposure to light. Light is an extremely potent stimulus to our brain that tells our brain it's time to wake up. So there's a direct connection from your retina to that suprachiasmatic nucleus that says, hey, stop producing melatonin. It's time to then switch from being awake to being, or from being asleep to being awake. So I have my clients, when their wake up time occurs, that they open their blinds. Hopefully the sun's out. If not, then it's flipping on lights. So that light exposure tells your brain it's time to wake up. And then the flip of that is having your bedroom, when you're trying to sleep, have it be as dark as absolutely possible. So if you do have a clock, clocks are terrible to have in the bedroom for many reasons. If you tend to be a clock watcher, but cover up that clock so you don't have that light being emitted. Sometimes people will wear, like a mask. I tend to just put like a t-shirt over my eyes, so it doesn't have to cost money, but really you want your bedroom to be dark. Now, I will say though, that for some of the clients that I work with that are at a fall risk, we do talk about being safe, and safety is a big important thing. So for some of those individuals, I'll encourage them to have night lights if needed, if they have to get up to go to the bathroom, or for stimulus control. Because I am encouraging them to get out of their bed if they're not sleeping. So do keep in mind safety, absolutely. The other thing to think about is how we increase sleep drive. And there's, again, different ways to do that. So one thing to think about and to incorporate is a concept called stimulus control. And so basically, stimulus control means that if you are in bed, you're sleeping. And if you're not sleeping, then you're out of bed, because you want your brain to associate that bed with sleeping. You don't want your brain to associate the bed with being anxious, with being worried, with pain. So if you are not sleeping, you should be out of bed. And again, we'll talk a little bit more in detail about that. And again, being mindful about fall risk. So for some of the clients with older adults that I work with, or my clients with multiple sclerosis who are at a fall risk, I do not have them get out of bed for stimulus control. I instead have them do a relaxing or distracting activity in bed. So keep in mind safety. I can't stress that enough. The other thing to increase sleep drive is to avoid naps. And because what happens is, if you think about that figure where the sleep drive is building up during the day, if the person then takes a nap, that sleep drive is going to dip. And then it's going to take longer for that sleep drive to build back up. And so what I counsel to patients, because there are some clients who really, they need to take a nap. And I fully trust people to know their bodies best. And if they say they need to take a nap, then by all means do that. But certainly, limiting it to no more than 30 minutes, trying to do it as early in the day as possible. And then just knowing that if you do take a nap, you may have to delay your typical bedtime until you're adequately tired so that you fall asleep quickly and easily. Another great way to increase sleep drive is through exercise and physical activity. And this, again, is where I think our role as physical therapists can be a really tremendous asset, because we are really good at helping to promote exercise and physical activity. And I think particularly in clients who have persistent pain, who perhaps are fearful of being physically active, I think those are ways that we can help modify the activity or help coach them through doing these activities. Other techniques that we use is so we've now talked about the two ways to increase the two physiological drivers of sleep. The other thing to think about and to incorporate is ways to decrease pre-sleep arousal, right? So we've strengthened the circadian rhythm, we've strengthened sleep drive. Well, we're only asleep for 7 or 8 hours out of the 24-hour cycle. So what are we doing with the rest of our time? So it's really important to reduce the sympathetic nervous system activity, particularly in people with chronic pain or in pain, through relaxation techniques, because it helps keep that sympathetic nervous system, that stress level, hopefully at a reduced, more manageable level. So again, when they get into bed, that really strong circadian rhythm, that really strong sleep drive, that reduced sympathetic nervous system activity, they're at a prime position to fall asleep quickly and easily. So we do focus on relaxation techniques, and there's lots of different ones you can do. And then also focusing on a relaxing bedtime routine, because that again helps to reduce that pre-sleep arousal. It also helps to prime the brain to know that what comes next is going to be your bed, which means sleep. And again, we'll talk about these in more detail. And then also considering other, what would be called sleep hygiene techniques, so other behaviors and environmental factors to consider to help promote the sleep environment as best you can. So things like avoiding caffeine, avoiding nicotine, making your bedroom as dark, as cool, comfortable as you can. So now to go in a little bit more detail, to strengthen that circadian rhythm, again, I mentioned waking up at the same time every day. Because that does help set the circadian rhythm, and then when you're really diligent about your wake up time, your bedtime generally falls in line after that. For some clients, I do have to consider encouraging them to schedule a morning time activity to help motivate them to get out of bed, or to have something that's somewhat rewarding. Some people, I've had clients who like coffee, and there's a specific coffee they enjoy, so that's kind of their reward for getting out of bed. Or maybe there's a show they really like to watch. It varies for the person, but kind of talking about what are strategies that they could use to help get them out of bed. And so again, I don't typically set a bedtime, just because I don't want them getting into bed until they're adequately tired. But I usually set kind of we negotiate a time frame for when they want to try to get into bed. But if they can't fall asleep within 15 to 20 minutes, again, they're doing stimulus control. So then they would get out of bed and then do something relaxing. Exposing to bright light first thing in the morning to help set that circadian rhythm. And there's of course the exceptions. There's some people who have a shifted circadian rhythm. And so for those people, particularly if they have a shifted rhythm early, then you actually want to limit their light exposure in the morning, because you don't want the brain to think it's time to wake up yet. So those actually, you recommend that they are exposed to light in the afternoon and even into the evening. And for these individuals, melatonin might be helpful. Generally, melatonin is not prescribed for people with insomnia, but it can be helpful for people who have a circadian rhythm shift. Now, people who have a circadian rhythm shift, these may be people that would benefit from a provider to do behavioral sleep medicine, because there is an art to, you have to do it correctly when you apply the light and when you prescribe the melatonin. So do be mindful of that. And there is some evidence that bright light, there was a study that was done in military veterans who have low back pain, and they actually found that exposure to bright light first thing in the morning actually helped improve sleep quality and reduce their pain experience. And there's also some evidence that melatonin might be an analgesic. So that's some emerging research that still needs some more study to determine if that really is indeed the case. So we've mentioned sleep drive, and so that really is the concept if you want your brain to associate your bed with sleep. And you don't want your brain to associate your bed with being worried or anxious or pain, for that matter. So the recommendation is to leave the bed if you're unable to fall asleep, or maybe you've gotten up to use the bathroom in the middle of the night. So if you can't fall back to sleep within what feels like 15 to 20 minutes, so I tell people, again, no clock watching. Or if you start to feel worried or anxious that you're not sleeping, so that could be within a minute, then the recommendation is to get out of bed and go to what I've called the cozy nest, which I don't think that's really the best term to use, but it's the term that we use. So you're going to a place where you can then, you have it set up, you have a plan on what you're going to do for a mildly pleasant, relaxing, and distracting activity. So it could be, listening to a book, it could be listening to music, it could be relaxation, it could be meditation, it could be prayer. I talk with my clients about what that activity would be and where they're going to do it. So that way they have a plan in place. And then the recommendation is not to return to bed until you're sleepy. And the recommendation then is to do that as often as needed. And I fully understand that this may sound like cruel and unusual punishment, but I will say that the people who are very adherent with stimulus control, their insomnia improves much more quickly than those who aren't. Because again, it's so important to break that association between the bed and not sleeping. But again, I've mentioned being mindful about fall risk and also mobility limitations. So for some people, I do not have them get out of bed, but I instead have them do a relaxing or distracting activity in bed. So we talked about avoiding daytime naps, again, as best you can. If you do feel like you need to take a nap, then limiting it to less than 30 minutes, trying to do it as early in the day, and then just being mindful that you may have to delay your bedtime if you do take a nap. Now, I do want to say at this point that, for people who are in pain, or my clients with multiple sclerosis who have fatigue issues, taking a rest break is not the same thing as taking a nap. If your intention is not to fall asleep, then you should not be doing your rest break in your bed, and preferably not even in your bedroom. Because again, we want your brain to associate the bed with sleeping and not with doing other things. So if your intention is to rest, and that's great, by all means do that, but don't do that in the bedroom. And then if there's a chance that you might fall asleep, I'd recommend that you set a timer. So that way, if you do fall asleep, your nap then, so then it becomes a nap, is not prolonged. Exercise, and I've included a lot of information here, and not that I'm going to necessarily read all of this to you, because I do need to move through these slides. You all know that exercise is good for you for lots of different reasons. There's also plenty of evidence that shows that exercise and physical activity also promotes better sleep, both increases sleep duration, also increases sleep quality. And I think as physical therapists, we're in a great position to help optimize the movement and encourage physical activity in people with chronic pain, and to help coach them on how to do that safely and appropriately. There is some evidence that doing moderate to vigorous exercise very close to bed time can be disruptive, but the general recommendation is that exercise is good regardless of time of day. So there was this big poll in America, and they found that doing vigorous to moderate activity less than 4 hours or more than 4 hours, there was no difference in their sleep. But I will say that there is emerging evidence that shows that if you do moderate to vigorous exercise very close to bedtime, so I'm talking like within 30 minutes, that can in fact be disruptive to your sleep. Now, I will say in all the clients that I've worked with to help with their sleep issues, I've yet to find a client where performing exercise close to bed is actually disruptive of their sleep. But if you're finding that with your client, or if you have a client who is exercising really close to bed, then by all means, encourage them to exercise earlier in the day if possible. There's also evidence that more meditative type movements, so like Tai Chi, Qigong, and yoga, that can also be improving of sleep quality. And I would suspect it's different mechanisms than in those more aerobic type exercises, whereas these are more meditative, probably reducing sympathetic nervous system activity. But they do seem to be effective. And then decreasing pre-sleep arousal. So developing a relaxing bedtime routine, you got to find what works and then be consistent with it. So this is going to be highly variable from person to person. Examples would be like taking a warm bath, reading a book, meditation, journaling, those sorts of things. But the key is that it becomes consistent, so then your brain knows that what comes next is going to be the bed and sleep. And then thinking about what you're doing during the rest of the day and practicing relaxation techniques during the day, so to help reduce that sympathetic nervous system activity during the day. So in our interventions, we focus on deep breathing. We do 5-7-8 breathing, where they breathe in for 5 seconds, hold it for 7, exhale for 8. We also focus a lot on mindfulness to help our clients be more mindful of their thoughts and their behaviors. and then also progressive muscle relaxation. So those are the 3 relaxation techniques that we focus on. There's lots of different ones that can be used, and the best one is the one that's going to work for that particular client and the one that they're actually going to do. But the key is to practice. I have all my clients practice it during the day, and I encourage them to not use these relaxation techniques until they're proficient at doing it during the day and they're able to elicit a relaxation response before they try doing it at night. So that is also key. And then journaling is something that for some clients, I'll suggest to see if they're open to that. And that takes many different forms. So for some people, it's writing a to-do list if they're worried about, they forgot to do stuff while they're laying in bed. For some people, they've liked keeping a gratitude journal. Or some people like to use it as a way to process their thoughts and their emotions or the events of that day. So again, journaling isn't something I would suggest for everybody, but for some people who seem like they might benefit from it and are open to doing it, then there's different ways or different forms that journaling can take. And then absolutely, again, remembering to refer if needed to, these are suggestions, psychologists, psychiatrists. Again, if in your conversations it's apparent that there's been a past trauma or ongoing trauma, or if there's a depression, anxiety, or other mental health concerns that may be disrupting their sleep, then knowing to refer those individuals. And then making sure that you're mindful about what you're doing before bedtime. So the recommendation is to get off screens an hour or 2 before bedtime because that blue light can reduce the amount of melatonin that gets secreted. And then also, the content can be stimulating, and then it's also a time warp. People a lot of times get on their devices and intending to be on it for 5 or 10 minutes, and then, an hour goes by. So it's kind of that combination of blue light exposure, content exposure, and then just time. So being cautious of those things. And then caffeine, that's probably fairly obvious, to avoid caffeine in both food and drinks at least 4 hours before bedtime. Caffeine has a half-life of about 6 hours, so meaning that whatever caffeine you consume, you still have about half of it in your bloodstream and 6 hours later. So I do sometimes have to counsel people on, kind of planning on when they're going to stop consuming caffeine, and then also educating people that decaffeinated does not mean no caffeine. That even in decaffeinated beverages or food, that it still contains some caffeine. And then alcohol, that's a conversation I oftentimes have. People may use alcohol to help them fall asleep, and it is true, it may relax you and help you fall asleep, but it actually can disrupt your sleep. And then smoking is a stimulant, and then, counseling people to stop smoking or refer them to a smoking cessation program. Being mindful of your meals, avoiding large spicy meals before bedtime, and then also being cautious about liquid. This is probably more true in my older adults, talking about avoiding excessive liquid. I don't want anybody dehydrated, so obviously consume liquid if you need to, but being mindful about not over-consuming liquid either. And then we'll talk about safety techniques as well if they have to get up to go to the bathroom, because ideally, if people do have to get up to go to the bathroom, then you want to make it as low stimulation, low light as possible, so that way when they do get into bed, they're able to fall asleep quickly and easily again. The sleeping environment, we've talked a little bit about this, reducing the light as much as you can, reducing noise. There's evidence in people with chronic pain that they actually are more susceptible to hearing environmental noise. And so this will be something you want to counsel those individuals about using earplugs or a white noise machine can be helpful. And then also temperature. There's no magic temperature to set your thermometer or your thermostat at, but you generally want the environment to be somewhat cool. So not too hot and but not too cold either. And then again, referring is needed if the individual does need further assessment or other healthcare providers, and then as well as community resources. So thinking about positioning, that's again, I think within our PT wheelhouse that we're really good at. So helping our clients who are in pain or have other various conditions, what position might you recommend or help them to problem solve through? And then other challenges that you might have to consider. People with limited mobility, we've talked about fall risk. Some people have cognitive impairments that you may have to involve the care partner or the bed partner to help with some of these techniques. We've talked about the rest breaks versus naps, and then other comorbidities that you may be treating the individual for. I did want to include a list of medications that can interrupt sleep. You'll notice that opioids are on there. So these are medications that if your clients are on them and they have disrupted sleep, it may be worth talking with their physician to see if that could be also contributing to their sleep issues. There's lots of different free tools out there. There's lots of relaxation techniques. This is an app that I like to use. And then there's the mindfulness coach that helps guide people through mindful practices. And then the the Breathe and Relax app, that's another free app. So just a couple of free resources that I tend to use and are freely available. Here's some websites if you would like to learn more about sleep and ways to promote sleep health. I'm going to present a couple articles that or suggest a couple articles. This is that Finnan paper that I think is really well done and very interesting if you're interested in digging more into this association between sleep and pain. This was a paper written and published in PTJ just a couple years ago, and this is specific for physical therapists working with clients with pain. And then a couple other papers. This is a Prospective paper that we wrote that's broader. It's not specific to helping clients with pain conditions, but a lot of these techniques certainly could be applied. And then again, I didn't have time to talk about social determinants of health, but this was a paper that we just had published this year that talks about needing to assess social determinants of health and how to do that in patients. And then that's where I'll end. So here is my email. I'm happy to continue discussing via email. I'm pretty active on Twitter, and I'll look forward to hearing your questions in the question and answer time.
Sorry about that. I need to unmute. Yes, here we go. Thank you for the talk. That was really good.
Thank you.
Informative.
I'm glad you thought so.
Yeah, it was really good. And so we will be taking questions. I do understand there is a 2-minute lag. We did have a couple questions come in, so I'm going to go ahead and put those up on the screen. And then you guys just send in your questions and we will get to them. So the first question is from Stephanie, and she asks, with the easier PSQI, you indicated that you must request to use the scale from PIT. With the easier scoring format, which is a Google Drive doc versus the PIT, EDU link, do you have to request to use this easier scaling document?
Good question. Yes, would be my answer for that, because it still is the Pittsburgh Sleep Quality Index, and it's free to use for clinical purposes, even research purposes. It's just not intended to be used as for commercial or for profit. So the easy version, it's still the Pittsburgh Sleep Quality Index. It's just been reformatted, and it has the scoring available on that form. It used to be available on a link that was no longer available, so I dropped it into my Google Drive and have shared that. But yes, technically you should ask for permission to use the Pittsburgh Sleep Quality Index. Okay,
and our next question comes from Jim, and the Q&A box does kind of cut off the few letters at the end. He says, I've been told by the physicians in my area can only do sleep studies for suspected obstructive sleep apnea. They do not get reimbursed by insurance for any other type of sleep study. Is that a common practice?
That's somewhat surprising. The neurologist that I work with, where I do my overnight sleep studies, she does overnight sleep studies for lots of different reasons. Obviously obstructive sleep apnea is a very prevalent issue. So she does see a lot of clients for obstructive sleep apnea, but also for restless leg syndrome, periodic movement of sleep. So that's somewhat confusing, I think, to say that he only does overnight studies for obstructive sleep apnea. It is true that there are some reimbursement, I guess I don't want to say concerns, but the procedures you have to follow for reimbursement for prescription of CPAP. I wonder if maybe that's what he was referring to, because oftentimes insurance will require that you actually do an in-home sleep study first. And then if the in-home study shows that you have, without a doubt, or fairly confident that you have obstructive sleep apnea, then they go ahead and prescribe you a CPAP or BiPAP. But if it's somewhat inconclusive, then you do an overnight sleep study to diagnose sleep apnea. So sorry, that's somewhat confusing on why they would only do the overnight sleep studies for sleep apnea, because there'd be other indications for why you would do overnight sleep studies.
And another question is from Adi, and she asks, what are your thoughts about sleeping pills? You get asked that a lot.
I'm wondering if I go through my long spiel or my short spiel. Maybe I'll go somewhere in the middle. I mean, I think my issue with sleeping pills is that they are way overprescribed. I'm just going to say that, and I'm going to throw that out there. I think that oftentimes when people do have insomnia, that's what physicians they give out. But really, the recommendation for insomnia is to do CBTI. That's the recommended first step to treat insomnia. Now, that being said, there may be some people who for short term maybe do need a sleep aid in the short term. So absolutely, I don't want to say there's no indication for sleeping pills at all. But what I oftentimes see in the clients that I work with is that once they're prescribed a sleep aid, they're on it for a long time. And we know that they become less effective, and they become a crutch. I mean, they become something where I've had people who are so worried at the idea of getting off of their sleeping pill, because it's like, if I don't take this sleeping pill, then I will not sleep. And it's like, well, let's experiment with this. Let's try this. Obviously, you came to see me, so you must be willing to try CBTI. But there's so many people that get so concerned about staying on those sleeping pills. So anyway, I'll step off my soapbox, but they are way overprescribed, and I'm certainly a big proponent of doing behavioral interventions because those are shown to be very effective.
Okay, we actually have another question coming in. When practicing some of these sleep habits, this is from Joel, sorry. When practicing some of these sleep habits, what kind of timeline do you prepare patients for to see results? A week, 4 weeks?
That's a great question. And like most intervention, it depends a lot. The CBTI protocols that we do 6 weeks. But I have some clients who, after I see them one time, they come back in a week later. And so we see them one time a week for 6 weeks. They come in one time, and I see them the next week, and their sleep is dramatically better. That's not uncommon. If they, so it kind of depends on what's the underlying issue contributing to their insomnia. That's the big key. For some people, like for an example, I had one person who was having insomnia, and she was checking her work email right before bed. And so, of course, checking the work email, I suspect she probably was doing other things on her phone as well. So she was spending more time on the phone. And then, of course, the content of thinking about work then right before bed was, disrupting her ability to fall asleep. So we did a behavioral experiment where she experimented with not getting on her phone right before bed, and with the next week, her sleep was dramatically better. And then there's other people who have some other, I think, more complex issues underlying their sleep issues. So for people who do have persistent pain, that can be a big difficulty. For people who have become anxious about their sleep, which again, for a lot of people who we see, they've had sleep issues for years. So a lot of people we work with are pretty anxious and concerned about their sleep. So for some of those people, it can take a little bit more time because of how we introduce the relaxation techniques. And of course, it just takes some time to practice those relaxation techniques. But I will say, for the clients that are very adherent with a regular wake-up time, and they're very adherent with stimulus control, those are the people that have much quicker results than the people who are less adherent or who have much more difficulty with doing those kind of big tenets of CBTI.
All right, and we have time for just one last question here before we end the Q&A, and this one's from Justin, and he asks, even though commercially available sleep trackers aren't too accurate, are they helpful at all when looking for trend improvements?
Absolutely, and I think that's a valid point, you know, because no, we know that they're not very accurate, but there still are some benefits to them. And I will say that if you're using it like, you know, within the individual and looking at, you know, changes in their sleep over time, then absolutely they can be useful. You know, I just always couch it with, you know, just to be aware that this could be over underestimating or underestimating your sleep duration and quality. So I tend to focus more on, you know, how are they, you know, when they wake up, how would they rate their sleep quality versus the device. But yeah, there's definitely utility, and especially for the people who really, you know, because there's some people who are really, really interested in the data coming from their wearables, and so absolutely capitalize on their willingness to, you know, experiment with things and then see how it affects their sleep or their physical activity levels. So yeah, there's definitely some good use of it as well.
Cool. Well, thank you so much, Dr. Siengsukon. And for the attendees who have purchased a Backstage Pass, you will be joining us in the Zoom discussion room that you received in your email this morning.